Good afternoon. My name is Charles Melone. I'm a hand surgeon from Manhattan, New York. But that's what I call a poster hand. Now, the basic concepts of surgery, you need to prioritize, and certainly we all know scleroderma is a multi-system process, and there are other organs such as the heart, the lungs, GI tract that take precedence over the hand because they have a mortality rate associated with them, whereas the hand, nobody's really going to have a mortality rate from hand involvement. But it is a very important functional problem. Now, the basic premise here is to be, when you're dealing with the hand and hand surgery, be conservative but aggressive at times. And what you're seeing here is a dorsal ulcer over the tip of the finger joint, the index finger, that was recurrently infected, and this patient initially was sent to me for amputation. And the rheumatologist said to me, Charlie, you know, we got to be able to do something better than amputation. This finger looks pretty good, but it's been chronically infected, osteomyelitis, and a major source of disability for about a year. And the doctor wanted to amputate it. And I said, okay, well, what we'll try is what you call a fusion. This is the way the finger looked before, and this is the osteomyelitis in the joint. We cleaned up the infection, infused the joint. It's joint fusion right there. And that's the appearance of the finger following completion of the healing process. Aesthetically very appealing and very functional finger. The patient was able to go back to work with to her, a normal finger. The first time she was able to use this hand and this finger in over a year. So in this case, we were aggressive in the sense that we did go right ahead and say, no, we're going to operate on this finger, make sure the patient was stabilized, but went ahead and did the surgery. And I would like to dispel a few common myths about scleroderma, and that is surgical wounds will heal. In contrast to what many people hear, that there are very few hand surgeons who deal with scleroderma for that reason, because of the poor circulation, the vascular problem involved with scleroderma. Most are afraid that their wounds will not heal. What I would like to show you is that the vast majority of surgical wounds will heal, and it's the exceptional case where you will run into a problem where the wound will not heal. And another very important concept here is that hand surgery should be considered, since the hands are involved in virtually 90% of people with scleroderma, if not more, if not all. I don't know, how many people here have hand involvement? There's so many people who don't know that surgery is available for scleroderma. And I think that's another message that we have to get across. But it is a key component of treatment and should never be considered a last resort. If you have a stable patient, as we're talking to one right here, and they're having a problem with their hands, operate on the hands just like you would a, quote, normal person. Because to me, scleroderma people are normal people, and they deserve all the benefits that surgery has to offer, and there are a lot. The goals of surgery: correct deformity. Again, here you see the classic contractures of diffuse scleroderma, and correct deformity, alleviate pain by clearing up, mainly by clearing up the ulcers, the dorsal ulcers over these joints, prevent tissue loss, increase function, enhance aesthetics, and very importantly, improve the quality of life. I mean, you fix somebody's hand and they can use that hand again. I mean, you're giving them independence that they haven't had for many, many years, and it's so important to them, particularly for the females, and which the vast majority of people that I see with scleroderma are females, and just to be able to comb their hair, brush their hair is so important, and things like that we take for granted every day of our lives. You know, it's so important, and to improve self-independence. Nobody likes to be dependent, nobody. And these are all the goals of surgery, and in most cases we can achieve at least some of them. Basic surgical principles, newer techniques, making surgery much more successful. And there's somebody using a microscope, and I think you can tell who that is if you look very carefully. I'm a dead giveaway because of the size of the earlobes. Revolutionized surgery, really. But careful patient selection, very important. And of course, thorough peri and operative planning. You really have to know your patients. You have to know what their problems are and what you have to be aware of. You need a knowledgeable staff. Scleroderma is something that there's not too many people that are familiar with and that operate on. And my staff, actually I have PAs who know more about hand surgery, and particularly more about scleroderma, because in New York, we see a lot of patients that require surgery. We get referrals from all over the country. I just had one from Cleveland Clinic from Northwestern. But from Colorado, from California, from Texas, from all over, and our staff is very familiar with the needs of the patient. Surgical techniques must be precise, and of course skillful anesthesia. One of the major advantages of doing hand surgery in scleroderma patients is that you don't need general anesthesia. Okay, so that avoids any potential problems you might have with pulmonary problems, cardiovascular problems. Doesn't avoid it completely, of course. You have to sedate the patient, and we do want them to snooze through the operation. It's not too much fun for the patient if they're wide awake and they feel everything, so we do give anesthesia. But they don't need general anesthesia, which is a big, big advantage, right? And the regional anesthesia is extremely important. And then post-operatively, intensive rehabilitation. It takes usually about 8-12 weeks for these wounds to heal, for the bones to heal, but it certainly is worth that 3-month wait when people have been dealing with this for 3 to 10 years. Right? Now the indication for surgery is based on the subset, diffuse versus limited. That's your classic diffuse systemic scleroderma hand that we saw before. And it's characterized by the disabling joint contractures. The PIPs, if you look at my hand, are in hyperflexion or flexion contractures, and the metacarpal phalangeal joints, the bigger knuckles, are held up in extension. So essentially you have a claw hand, right? And often this progresses, many times it progresses without treatment, to the point where the fingers are actually locked in the palm. That's something we're seeing less of now, fortunately, because the treatment is much better now, and they're coming to see the surgeon much sooner now, and we're operating on them sooner. But we have had patients with fingers locked into their palm, and they could not grasp anything. Sometimes the thumb is locked across the palm with the fingers over the thumb, so you can get very, very bad contractions with the diffuse type of scleroderma. Okay, and limited is less joint contractions, but this is where you see more troublesome Raynaud's phenomenon. It's called syndrome, phenomenon, disorder, everything but disease. It's not Raynaud's disease. That's a separate problem. And the limited version, that's where you see the calcinosis. And to me, the two are inseparable, Raynaud's and calcinosis, because they're based on the same problem, and that is a paucity of circulation to the hand. And they both result in digital ulceration. Here's the Raynaud's. You know the color scheme, right? White. Goes from pink, which is normal, white to ischemic, and then blue, the venous stasis, and then back to white. And then we have the calcinosis, and here is pretty diffuse calcinosis, which is, again is characteristic of limited scleroderma. And with both lead to ulceration, infection, and impending amputation. So these little ulcers can become big ulcers to the point where they really become troublesome. where they threaten the viability of the entire hand, especially when they become infected. Okay, so the types of surgery that we perform for the diffuse type, for the bad joints, arthrodesis, which is fusion of the joints, and arthroplasty, which is actually replacing the joints. And that's something relatively new that we have tried, but these are the types of surgery. So it depends on the type of surgery, first of all, right? And then, and of course, the condition of the patient. And then for the limited type of scleroderma, this is where the digital sympathectomies come into play and the calcinosis excision. And I usually combine the two now. When I do a calcinosis excision, I invariably will do a digital sympathectomy with that to improve blood flow, because it's a poor blood flow that leads to the calcinosis formation in the finger. But once again, they both create very troublesome ulceration, very painful ulceration. Ulcers that become infected, ulcers that threaten the viability of the hand, ulcers that for many people in the past have resulted in amputated fingers. And these are all things that I think can be prevented, and we have prevented them, at least we're in our neighborhood. Okay, so this is I think the mainstay of scleroderma treatment, and that is arthrodesis. And if you look at this hand, this is a front end-on view of a hand with flexion contractures, and you can see the white area, the ulcerated area, and this has been ulcerated. It heals over, it gets infected, ulcerated. But one thing you see here, and just remember that, because you're going to see at the end here, after the 8-week period of healing, that's how long it took this to heal, 8 weeks, right? And this patient went into therapy and started using the hand. But you cannot see the nails in this patient. So just remember that when you see the outcome, okay? And this is X-rays of the same fingers, and you see the severe flexion deformities. These joints are actually totally deformed. And here, the next slide, you see the incisions that we use. We create very carefully designed flaps because we're very concerned about circulation. And the fusions, what you actually do with the fusion is you remove the bad part of the joint, right? Remove the bad part of the joint, and you get the subchondral, or the part just below the joint, to heal together in the position you want, a much more functional position. So you're taking a bad joint that's like this, okay, and you're bringing it up into a much more functional posture like this. And what you want is bone to heal to bone, the same as if you had a fracture. And that's what a fusion is. So you're sacrificing motion at that one joint, but remember that the finger is a linked system, and you have motion here at the MP joint. This is the one you fuse, it's a PIP joint, and you still have motion at the DIP joint. So the patient can still do this. Because you don't wind up with a stiff finger, and that's another misconception about a fusion, that you're going to wind up with a stiff finger. That should not be the case. It should be a mobile finger and a much more functional finger. And no pain, no ulceration, and no more infection. And the way we fix these fusions is minimally invasive. There's no fancy plates, no screws, nothing that can irritate the skin, because we all know how thin the skin is and how thin the extensor tendons are and the soft tissues and scleroderma. So you don't want to put anything bulky over a fusion site, because ultimately what we've seen so many times is that the fusion device will penetrate right through the skin. And that leads to infection, but we have to take it out. The fusions never heal. So be minimally invasive, and these are what we call Kirshner wires, simple wire fixation. But the key to this whole thing is to get the bones in excellent coaptation so they're solid, right? And you could put toothpicks across them and they'll heal. And here you see, this is about 8 or 9 weeks later. Much more functional positions. much more functional positions, and you have a solid fusion at every one of these, right? So the fact, this whole concept that fusions will not heal, it's not true, right? See how beautifully that healed? You still have motion at this joint, you still have motion at this joint. Okay, now this is the same hand that I showed you before, the front-on view. It's certainly not perfect, but what you can see here, remember I said look for the nails, right? Okay, so what this is showing you is that these fingers are in a much more functional position. This patient can now grasp down to the palm, not complete, not a full grasp, but a good grasp like this, down to the palm where you can see the fingertips, and there's no pain, there's no ulceration. You see over the top here. No more of those white marks that you saw before, right? No more infection. And no more pain. I know you had a question about the healing process. It takes about 8 weeks for these fusions to heal, and we have done probably over 300 of these now, and 97% of them have healed within 8 weeks. If it looks good, it works well. Plato said that quite a few years ago, right? Form and function. So there's nothing new about that, you know. If it's going to work well, it's going to look good. So that's a big plus as well. So I brought that out in the very beginning, that aesthetics, one of the goals here is to improve aesthetics of the hand, because you have to improve the aesthetics to improve the function, or vice versa.
Do you do all 5? Do you do a whole hand at one time, or just
Yes.
do the whole hand at one
And
time?
an operation should take no more than an hour, 1 hour. Yeah.
Is Medicare?
But then
gonna pay
again,
for
we
this?
have done over 300 of these. So, but yes, you don't want to bring the same patient back 4 different times for the same operation.
Would this be covered under Medicare?
I think so. It is in my office. It's covered under all insurances.
Hi, good afternoon, doctor. I am a musician. I've played piano all my life, and I've had scleroderma for 6 years. I've retaught myself how to play the piano, and I currently do play. What would that do to my piano skills if I had the surgery?
I'm sorry. What was the last part of the question?
Well, since I'm a pianist, what would and I've relearned how to play with my scleroderma and contractures, what would the surgery do to my ability to play? Would I have to relearn all over again? And would I have the ability to play the piano?
I would think it'd improve. I can't see how your hands are now, but why don't you come up?
Okay. There you go. I guess actually. Okay.
Well, I'm not sure we could give you too many more octaves, but I know you could play better. Your hand would be like this. Wouldn't that be better for you?
It would be. I've just kind of relearned how to play now, but
Well, just remember what you're seeing here.
okay. And so even if they're straightened out like that, I would just have to,
It comes natural.
it comes natural.
Absolutely.
Great.
You should have it done.
Doctor?
That's what you like, a motivated patient with a goal. You have your own goal, and there's absolutely no question in my mind. You would play, and you'd play more, you'd play better.
Doctor, is there any other doctors on the West Coast that is doing this that you know?
At UCLA, there was a doctor there named Neil Ford Jones, Dr. Jones, at UCLA. So you might check with them, okay? They're not as good as the people in Manhattan, but they're okay. You know.
I have a question.
No, they're better. But
Rather than hands, are these surgical principles being applied to foot surgery with success in terms of infections and rehab?
simply stated, no. I'm not a foot surgeon. I can't speak for them, but why they're not doing more, I'm not sure. But I think it goes back to the concept that I said before, that they're afraid the wounds will not heal, and particularly in the lower extremities where you have a lot of peripheral vascular disease to begin with, I think they might be more reluctant to do surgery there. So it's a lot easier, seriously, and it sounds gross, but to amputate a toe than it is to amputate a finger. It's unheard of in my profession to amputate a finger for scleroderma. Right? What they do in the feet, they may say it's gangrenous, it's beyond repair, or whatever, but it's just not the same. The foot is not a hand, right?
Can this kind of surgery work to repair my thumbs so that they're usable again? That's really not in here, but I think it is in the handouts that I gave about adduction contractions of the thumb, right? Yeah.
The classical posture of the scleroderma hand is this, which you see on every one of these pictures that I've shown. So yes, there is something that can be done. And for the thumb, what we generally will do is actually create a new joint, which is similar to what I'm going to show you right now, except you don't put an implant in. But by releasing the contracture, and this is all done in one operation, no distant flaps, no skin grafts, nothing like that. You just reconstruct the joint so that the thumb can come out more like this and move.
Great, that would be wonderful.
So it's a definite possibility, and I think that's one of the easiest things to do with scleroderma. Every patient I've shown you, and I think on your handout it has over 500 surgical procedures. We've never lost a finger, we've never lost a nail. Okay, so now MP joint arthroplasties, these are for the joints that are the other part of the claw hand. It's the big knuckles that are contracted like this. And what I started doing about 15 years ago is to not what they used to do, which never worked real well, still doesn't work real well. You just do what you call capsulotomy, just release the joints, release the tendons, but within a few months they'd be like this again. So what I did is what we do for other types of arthritis, and that is actually replace the joint. And here you see the joints that we use as silicone joint replacements. And again, all four are done at the same time through one incision. And that's the way they look when they're implanted into the fingers. There's 4 new joints in the 4 fingers. And this is an example of the patient who had the PIP fusions and then the MP implants, and this is 12 years later. And she's got beautiful hands. She's able to get her rings back on. Very happy lady. I defy you to see her incisions, which means you heal beautifully. People with scleroderma heal. That's the top of a hand. I think if you look very carefully, in any event, it's a much improved hand with the ability to pinch, as you see here. And the big thing, ability to comb her hair. It's the same patient. Again, now look at the posture of the fingers now. Again, MP implants, new joints in the big knuckles. The smaller knuckles are fused, and the terminal knuckles are not touched. Okay, so for the limited or crest syndrome type of scleroderma, one of the mainstays of treatment is to treat the digital ulcerations that come from the Raynaud's or come from the calcinosis. And here's an extreme example. This patient, again, was referred to me for amputation. I said, no way. We'll see what we can do. And what we did was clean up the ulcer. This is the same finger now. Clean up the ulcer, do a digital sympathectomy, and it's about 3 months later. And it's the same finger, and it's pretty remarkable that we're able to preserve her finger, and obviously a very happy patient, very happy surgeon, and a very happy office. Okay, now calcinosis comes in 2 varieties. One is the diffuse form, as you see here in the thumb. We call it calcinosis universalis. And again, this is related to very poor blood supply. All these patients have Raynaud's, but the reason for formation here is excretion for whatever reason. Nobody really knows why we get calcinosis. But we do know that there's excessive secretion of a protein, with a crazy enzyme in it that creates a calcinosis, which we all have normally. We have the same protein with the same enzyme. It's called gamma carboxyglutamic acid. And we have the same enzyme in our teeth and in our bones, but not to the extent where it becomes excessive as it does in scleroderma. And that's what you're seeing here. And so because we don't really know why this happens, there is no good medical management for this. And when it gets out of control, where it starts to form ulceration, or interfere with function, that's when we go to surgery. And this is a universalis form, and this is a more localized form that we call circumscripta. This has a much better prognosis. If this type of calcinosis that you have, you can excise this, and for most people, this will not recur. As you see right here, this has been excised, and this, up until this date, which is about 15 years now, has not recurred. Okay, now this is an example of a patient with the calcinosis and the Raynaud's, and the ellipses that you see out here and out here, this is where the skin had persistently ulcerated and became infected. We let the infection clear up. We decided to do, and there's calcinosis beneath this. Decided to excise the calcinosis, excise the ulcer, and make little flaps to resurface the area. You see here, the other incisions are for the digital sympathectomies. And what you're seeing right here, anybody faint of heart? These are the only surgical slides I'm really showing, but I just want to show you what these vessels look like and what they should look like. And what you're seeing right here is the fibrosis, which is part of scleroderma, except for collagen formation and fibrotic tissue overlying the neurovascular bundle with little arteries that are really about 2 millimeters in diameter. So you don't have good blood flow to begin with, and when you have scleroderma, it's really compromised. So what you do with the surgery, with the digital sympathectomy, or with other sympathectomies that you might hear about, is you remove the fibrotic tissue, separate the artery, which I'm doing right here, from the nerve. The artery up there, more fibrotic tissue that's adherent to the nerve, which is right there to the nerve. Separate the two. And that's just the way it should look. This is the artery. That's the artery right there. Nice and clean now, totally different from the way it appeared at first. And this is a digital nerve. And this little thing right here is a connecting nerve between the digital nerve and digital artery. And that's a sympathetic nerve, which is what we cut to eliminate the Raynaud's phenomenon. Okay, so you strip the blood vessel of the adventitia, the scar tissue, and you divide those little communicating branches that I showed you, and that's what the sympathectomy is all about. And you're also eliminating the fibro-occlusive component by taking the scar tissue away from the blood vessel. And there's both arteries that are totally cleansed of sympathetic innervation as well as fibrotic tissue. And then we go back to the tips of the fingers and remove the calcinosis, cover them with little flaps, and this is the hand. The middle and ring fingers have been operated on. You can see the scars at the base of the palm, and they've healed beautifully, and this is about 3 months after the surgery. So again, a very successful result, very happy patient. And this is my experience with the different procedures that we've done, over 500 procedures in over 250 patients over a 20-year period. You see the mainstay of the treatment is the IP joint ARTHRODESIS, and the microdigital sympathectomies are right up there, 130 of them, and calcinosis excisions. I think you see calcinosis in about 30% of the people that have scleroderma. So 36% cases there, or 36 cases there. And the results have been consistently favorable. And I think I can say this with all honesty, that you can expect solid bone effusion in 8 weeks, thorough wound healing in virtually every case. We have had no infections, no tissue loss, no finger loss, no nail loss. A very high level of patient satisfaction, and I can truly say, to me, it's a low-risk procedure, or they are low-risk procedures with a very high reward here. So.
With the successful hand surgery that you would perform, now, did I hear you say correctly that that would eliminate the Raynaud's phenomenon?
It does eliminate it, but it is not usually a permanent elimination. It can come back, right?
Just the Raynaud's and not the deformity?
Correct, correct. And then the one thing that is surprising to some people, and they have to be advised before, like I said, there are 2 forms of blood flow into the finger. One is nutritional and one is thermoregulatory. And they're both associated with Raynaud's, right? But what the sympathectomy does is improve the nutritional to heal the ulcers, the painful ulcers, but in many people has no effect on the cold intolerance, the thermoregulatory component, okay? And that's the part that goes away but may come back or may never go away. The nutritional blood flow seems to always be improved. That part does not seem to recur.
I have an additional question.
Yes.
If I had my hands repaired, what about my wrists? They are locked. Will they remain? Is that an option up the road?
You would have to have your wrists evaluated. There are certain procedures that can be done for the wrist to improve function, but again, it depends on many factors. You know, do you have arthritis in the wrist, or is it just the soft tissues that are tight that are holding you back?
The second. It's soft tissues that are tight that are holding me back.
Yeah. Well, that's something that should be treated medically, not surgically. Right? And as far as I know, the right medicine is not there yet.
Okay, thank you.
Right? But play the piano. That's the best therapy.